Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Welcome to the second day of the International Seminar on Autism 2014. Without further ado, we will begin the day with the third plenary session. The moderator for this session is Dr. Yasmin Hussein, the Director of SMAHM Regional Center for Special Education Needs, or better known with its acronym SMAHM. Dr. Yasmin, over to you now.
Dr. Yasmin sebelah kiri saya kanan.
Thank you. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Welcome back to the second day of the International Seminar on Autism Malaysia. I'm Dr. Yasmin Hussein, Director of SMAHM Regional Center for Special Education. I will be the moderator for this session. DSM-5, an effect on diagnosis and intervention. With us today is Dr. Ranjini S. Sivanesom. Let me first introduce her. Okay, Dr. Ranjini is a developmental pediatrician at the Pediatric Neurology Unit, Institute of Pediatrics, Kuala Lumpur Hospital. She received her medical degree from the Mangalore University, India. She is a member of Royal College of Pediatrics and Child Health UK. She did a year-long fellowship at the London Evelina Children's Hospital. Currently, she handles cases of children with neurodevelopmental issues. Her focus on autism includes establishing early diagnosis and coordinate appropriate intervention for these children. The DSM-5, ladies and gentlemen, why did it change from the previous version? What are the new criteria? How will these changes impact children or adults with ASD? Well, lots and lots of questions. And let us welcome Dr. Ranjini to address DSM-5 and effect on diagnosis and intervention. Welcome.
Very good morning to all present. I would like to thank Dr. Yasmin for her kind introduction. I would also like to thank the organizers for inviting me to speak. Now, interestingly, the DSM-5, if you look into your program list, it's written DSM-V, that's the Roman numeral. But if you look into the text, it's DSM-5, the number is 5. DSM-5, an effect on diagnosis and intervention, the discussion can be a little dense and maybe a little difficult for non-medical personnel to follow, but I've made it as simple as possible. More than happy to answer questions at the end of the session. So going back to history and autism, in 1943, it was first described by Leo Kanner, and then subsequently in 1970, autism was highly distinctive. It only embarked in 1980 when it was officially recognized as a diagnosis in the DSM-3. Then if you look at the trend, every 7 to 14 years, you will have a revision of the DSM. We had 1994, the DSM-4, which most of us use to practice at this moment. And then the 2000, we had the DSM-4-TR, text revision, which encompasses the diagnosis of autism requiring a criteria in each of 3 domains, mainly social relatedness, communication or play, and restricted interests and activities with onset by the age of 3 years. So the planning of DSM-5 began in the year 1999. There were 9 white papers. The purpose was to stimulate research and discussion to improve the scientific basis of future classifications. There were 13 global research conferences between the year of 2004 and 2008. The goal was to stimulate empirical research and promote international collaboration before the formal development of DSM-5. There were quite a number of work groups during this time frame between the year 2007 and 2012, and it was officially launched in May 2013. The goal mainly was to enhance the reliability, validity, and clinical utility of the Diagnostic and Statistical Manual of Mental Disorders for both clinicians and researchers. Now, this is the text that you have if you want to purchase for your department. But for Asians, we have a a revised version, a paperback, which will cost you about 170 ringgit, which you can order from the local bookstore. So if you really want to practice, it's good to have the paperback version. And you do have a desk reference as well that will cost you about 40 ringgit. Now the changes from DSM-4 to DSM-5, in the DSM-5, you had the in the DSM-4 you had the multi-axial component. Now in DSM-5, there's absolutely no axis. And one of the common things that you have in your autism diagnosis was PDD, pervasive developmental disorder, not otherwise specified. Now these were all replaced with either other disorders or unspecified disorders. The coded diagnosable conditions were 374 in total, and this was reduced to 324 now. Now, there were new disorders and their codes in DSM-5. Of interest, I will look at the topmost, social communication. And then if you come a little lower, you have the rapid eye movement sleep behavior. Then you have the restless legs. And then you have neurocognitive disorders, 10 mild neurocognitive disorders, 38 other disorders, and 30 unspecified disorders, which were put in to replace the not otherwise specified. The DSM-5 text revision disorders, which were combined in DSM-5, if you look at the topmost, you have got expressive language disorder and mixed receptive expressive language disorder. Now, it's important for the speech-language pathologists to come in with the changes of this current revision. Now, it's just coded as language disorder. And the second one, which I'll be going into details, will be autism spectrum disorder. If you come a little lower, you will see primary insomnia and insomnia related to another mental disorder. They just have insomnia disorder. And primary hypersomnia or hypersomnia related to another mental disorder, you've got an hypersomnolence disorder, sleep-waking disorder, and sleep terror disorder. Why I'm focusing on sleep is because in a lot of autism patients, you do have sleep disorders, which is often dismissed, all right? So it's timely to address this in your history and to look into what the current diagnosis is based on DSM-5. Okay, the nomenclature changes in the DSM-5. You have, of interest would be stuttering, which is replaced with fluency disorder. You have a transient tic disorder, which takes with a provisional tic disorder. Your sleep terror disorder and sleep-waking disorder, now they're more scientific. They're using non-rapid eye movement sleep arousal disorder, a sleep terror type. If you want to summarize, it'd be non-REM sleep. And then similarly, for feeding disorder of infancy or early childhood, you've got avoidant or restrictive food intake disorder. Now, it's interesting to look how the learning issues has been addressed in the DSM-5. The reading disorder, which is now having a diagnosis of specific learning disorder, with impairment in reading. Similarly, for your mathematics and disorders of written expression, it remains the same. Phonology disorder has taken a diagnosis of speech sound disorder. Now, coming to autism spectrum disorder, is a new DSM-5 disorder encompassing the previous DSM-4 autistic disorder, Asperger's disorder, childhood disintegrative disorder, and pervasive developmental disorder not otherwise specified. It's characterized by deficits in two core domains. Number one, your deficits in social communication and social interaction, and your second one would be restricted repetitive patterns of behavior, interests, and activities. So to make it simple, you've got your coding there, 299, that will be used in the US. Is important because this coding will be used until 30th of September 2014, and effective from 1st October 2014 will be your ICD-10, and your ICD-11 will be in 2015. So if you look at this, you've got two of them in the deficits of social communication, social interaction as one, and then you have a restricted repetitive patterns of behavior, interests, and activities. So the first one, so you've got total 5 criteria, which I'll go through with you slowly. Your criteria A has got persistent deficits in social communication, social interaction as manifested by the following currently or by history. Now I've highlighted the word currently or by history because your interview with the parent and the main caregiver is important. It is good to have in your practice prior that before the family comes, that it is good to have the main caregiver to come to your clinic. That's why, because history is important. Very often in our practice here in Malaysia, you have a parent who's seeing this child probably in the evening for about 2 hours, and I've got no clue about this child. And when you start taking the history, you say, I'm not sure, I don't know, I'm not sure. You're sitting on the fence, and here you are, the clinician, trying to establish a diagnosis, but you have a parent who's not able to give you the history. So it's good prior to the clinic to inform the family to bring in the main caregiver. Now, deficits in social emotional reciprocity. Now, it's impossible to ask your family patient, does your child have deficits in social emotional reciprocity? So what is good is to have a detailed pro forma in your practice to phrase out exactly what you want to say. So you can have abnormal social responses, and then with emotions, they've got reduced sharing of interests, emotions, difficulties in these issues, difficulties to initiate and sustain a conversation. Now, deficits in nonverbal communicative behaviors used for social interaction. Nonverbal can be abnormalities in the body language, abnormalities in the eye contact. Now, these issues need to be addressed as well. The deficits in developing, maintaining, and understanding relationships. Now, these kids tend to have difficulties in making friends, and absolutely no interest in peers, or even they can have difficulties in sharing imaginative play, pretend play, creative play, functional play, the whole load of that to be discussed. Now, in criteria B, there's restricted repetitive patterns of behavior, interests of activities manifested by at least 2 of the following. So you've got 4 major criteria here. You need to have 2. Now, stereotype are repetitive motor movements, use of objects or speech. Motor movements, you can have stereotypic, so any movements, you can have a flapping of the fingers and then repetitive finger play, those kind of things. Use of object, you can have a child who's lining up objects, lining up toy cars, lining up blocks, and speech can vary, really vary, because it can be somebody who's nonverbal to one who's verbal. Insistence on sameness, inflexible adherence to routines or ritualized patterns of verbal or nonverbal behavior. They have extreme difficulties to accept changes. They want to have the same routine every day, the same food every day. They just cannot, and they're very difficult to have transitions in their life. Number 3, highly restricted, fixated interests that are abnormal in intensity or focus. You have a child who's preoccupied, abnormal preoccupation with odd objects, all right? So you need to ask in the history, because sometimes parents may dismiss it, because you may have a grandparent there who says, oh, that's perfectly all right, and then the parents get a false reassurance that this is okay, and then they will dismiss this finding. And the other good thing to do is to ask parents to video the behaviors, and you want a clipping which is really short. Make it 1 to 2 minute video, not too long. So you have short clippings that you can see in the clinic and then make an impression from what you get there. Number 4, hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. Now, this really can vary. You can have a child with visual fascinations to either a movement, or you can looking into the movements of, maybe in the clinic setup, you have a curtain and then you see the movements of the curtain when the wind is blowing, or they have an obsession to a rotating ceiling fan or a stand fan. Then they have got excessive smelling or touching the objects, and then abnormal responses to a vacuum cleaner or a blender, and you can name, and then touching and taste aversion to particular texture. So your history taking must be really detailed. For those of us who are trained in some of the interviews, like you have, for those who are researchers, we have what is called ADIR. I'm sure the American standards are higher compared to us, but we are still far behind that. You have the ADIR, Autism Diagnostic Interview Revised. In a good hands, it takes about 45 minutes to 1 hour to take this detailed history. But for our setup, I think if you have a nice written pro forma describing each of this, and then you have a checklist, and then you can come to a diagnosis, I think you're fairly safe to make a diagnosis confidently. And of course, this needs to be accompanied with ADOS, Autism Diagnostic Observation Schedule. Now, that takes about 1 hour. So you're talking about 2 hours, just interview and then play-based, provided that you have a child who's cooperative. If the child is not cooperative, have got marked behaviors with regards to screaming, etc., refusing to come into your clinic, then it's impossible to run this assessment. So you may not be able to make the diagnosis at the first sitting, but call the patient to come back again do another assessment. Now, criteria C, symptoms must be present in the early developmental period. So you may have a child coming into you at 5 years of age. So a detailed developmental history is important to know what was the progression of this child, to look into the various developmental domains to see where the deficit is, but may not become fully manifest until social demands exceed limited capacities or may be masked by learned strategies in later life. D, symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. E, these disturbances are not better explained by intellectual disability or global developmental delay. Now, global developmental delay, some pediatricians love to use this word early developmental impairment. Whatever it is a diagnosis that you make at the initial setting, and it's for a child who's less than 5 years of age. About 2 weeks ago in our ward, we had an intern, an 18-year-old child, neurological complications in the ward, and then I saw in the notes it was written GDD, and I said, no, you don't make a GDD, you cannot keep this diagnosis at this stage, you need to have a revision. So diagnosis for the first few stages until you can establish a real diagnosis for this child. Similarly, for intellectual disability, it's really difficult because you need a clinical psychologist to do a detailed assessment, both for cognitive functioning as well as adaptive functioning, in order to make a diagnosis. But in simple practice, you just need to know, how do you differentiate now? Is this child an autism spectrum disorder, or is this child intellectually disabled? Now, in the intellectually disabled, the social functioning, the social communication and social interaction are markedly delayed compared to the nonverbal response. You could look into the fine motor skills, nonverbal problem solving. If you see this discrepancy, then you can confidently say that this is an autism spectrum disorder. Whereas in a child who's intellectually disabled, they are delayed in all areas, really down, really down. Of course, you have a score with 70. I mean, here we are with patients who don't understand the jargon of numbers. If you're a researcher, fine, IQ is 70, mild, moderate, severe, profound intellectual disability, he will give you something, but not for the parent, all right? What they want is, tell me, what is the intervention? That's my point of interest, all right? My point of interest is not all the jargon that you're trying to make very extravaganza, and so what's next, okay? Now, the severity levels of ASD, okay? Now, this is a little difficult because it's in English. And I was just thinking while I was reading this several months ago when I was giving this topic, and how would you convert this to Bahasa Malaysia, which is our national language? And if you look at level 1, it requires support. There's a social communication. I'm going to go through each one. If you look into the text, it's really very dense. I've made it as brief as I can at my utmost best capability, okay, so that the message is sent across. You look at the social communication, it's without supports in place, deficits in social communication causing noticeable impairments, the difficulty initiating social interaction, and atypical response to social overtures of others. And with the behavior, you have inflexibility of behavior, causes significant interference with functioning in one or more contexts, and difficulty to switch between activities, problems of organizing and planning hamper independence. Now, each of these words, if you look into psychometric assessments, they can be assessed. Each of these takes considerable amount of time. You have scores, you have centile charts, it gives you everything very beautifully. So in our practice, we need to be very practical. If you look at level 2, it requires substantial support, and column 2, marked deficit in social communication skills, limited initiation of social interaction, and reduced or abnormal responses to social overtures from others. And column 3, obvious interference with functioning in a variety of contexts, distress and or difficulty changing focus. So this is actually a descriptive. All right, now how are you going to draw a line is really difficult. And you look at level 3, it's very wordy, requiring very substantial support. Level 2 was marked deficit. In level 3, you see severe deficits in social communication skills, very limited initiation of social interaction and minimal response to social overtures from others. And for the behavior, you have inflexibility of behavior, extreme difficulty coping with change, or other restricted repetitive behaviors markedly interfering with functioning in all spheres, great distress or difficulty changing focus or attention. Now, it's too much to really at this point to explain to you, but all you need to know, there is a level 1, level 2, level 3. When you use DSM-5 to make the diagnosis, you are supposed to document the level of the severity. I'll come to that shortly. Now, there are a few specifiers. Now, you want to say, is this autism spectrum disorder with or without accompanying intellectual impairment? You must state. So you already made your diagnosis. Now your documentation, you put there autism spectrum disorder, and then comma, with accompanying intellectual impairment, or without accompanying intellectual impairment. Number 2, is it with or without accompanying language impairment? Now, with accompanying language impairment means you have somebody who's nonverbal, or somebody who has single words, or with single words, or somebody who's got phrased speech. But without accompanying language impairment would be one who's got fluent speech or able to speak in full sentences. So if you say with language impairment, in brackets you must put there nonverbal, in brackets single words, or in bracket phrase speech. Okay? Now, number 3, associated with a known medical condition. A medical condition can be an autism with epilepsy. So you will say, then here comes your diagnosis of epilepsy based on International League Against Epilepsy, or ILAE classification. Now, that's a detailed classification, so you need to put what type of epilepsy it is. And then the genetic condition, if you have, for example, a Fragile X syndrome, of course, you may not be able to confirm at this point in a first sitting, but you want to send investigations. Here in Malaysia, we have, previously it used to be the FMR1 gene analysis, but now we have the FRAXA and FRAXI PCR testing, which you can do. And then you have, of course, you have your tuberous sclerosis complex, you have your Rett syndrome, and you also can have your Down syndrome. Okay, Down syndromes can have autism, right? So you need to address this. And environment factor, what is environmental factor? When you're taking your history about birth history, you want to ask the mother whether they're exposed to any drugs. Now, for example, fetal exposed to valproate, all right, or epilim, better known, or it can be a fetal alcohol syndrome, and very low birth weight infants, severe prematurity. Associated with another neurodevelopmental, mental, or behavioral disorders. Now, this is really interesting because in the DSM-4, you're not allowed, if you have made a diagnosis of autism, then you're not really allowed to put autism with ADHD. You're supposed to spell out autism with comorbid inattention dash impulsivity dash. But this is interesting. With DSM-5, you're allowed to put autism spectrum disorder with attention deficit hyperactive disorder. You can look into conduct disorder, you can look into anxiety, you can look into depression, you can look into tics, you can look into sleep disorders, elimination disorders, feeding disorders, everything can be spelled out under this. And of course with catatonia, catatonia is not my field, it's the forte of the child psychiatrist, but catatonia is already mentioned as a specifier for your DSM-5. So the severity of specifiers for ASD is used to describe the current symptomatology, current symptom at the time that you are seeing the patient, and it may vary by context and fluctuate over time. Why fluctuate? You have a child whom you're seeing at this point, and then you're going to touch base in about 6 months' time. This child would have had intensive intervention, and then he's better. He may have been level 2, and then after that you will see level 1. And please take note, your level, when you're saying your severity, it can be level 2 for communication, but level 1 for repetitive behavior. It may not be the same level for both columns. The descriptive severity category should not be used to determine eligibility for provision of services. Now, this is a very important point. If you tell a parent, now your child is level 3 for both, and then you say services are not available, this is not acceptable in the DSM-5 because with good intervention, which Prof. Connie will be talking shortly, you will see remarkable improvement. Of course, parental commitment is important. So to summarize the important new changes in the DSM-5, for ASD, it addresses concerns about diagnostic conversion and diagnostic independence. inclusion of biohistory in the assessment of diagnostic criteria is extremely crucial. Now, individuals with the previous established diagnosis of pervasive developmental disorder should be given the diagnosis of autism spectrum disorder to ensure that service provision is, you don't close the door and say, no, you're now not an ASD, so there is no service provision for you. And thirdly, elimination of trumping rules that had previously prevented the co-diagnosis of attention deficit disorder or schizophrenia can be addressed in the setting of autism now. So what are the papers to suggest the DSM-5 validation? We have the Journal of American and Adolescent Child Psychiatry, which looked into this paper, Frazier et al. There were 14,744 siblings, which were taken from the Interactive Autism Network. It is a national registry. This is a hybrid model of categorical and dimensional criteria supported. And if you look into the sensitivity, you were to compare DSM-4 TR with DSM-5, the sensitivity has dropped 0.81. Whereas the specificity is high. Now with high specificity, you're happy, all right? Most of the papers are showing high specificity, but the only worry is at risk for false negative would be the female patients. So I'd like to address this especially to teachers, okay, and therapists who are dealing very often, because we know it's 1:4 for female to male, male to female, and so you will miss a female child with autism spectrum disorder where there is not much intellectual impairment. They go undiagnosed, and you know they have more of internalizing problems rather than externalizing problems. So you don't see them, they go undiagnosed, they live with the disability, all right? So people don't address their problem. So you need to look out not for the male patients, but for the female students who may have ASD. It's easier when the IQ is less than 70, when they're intellectually disabled. It's difficult when they are not intellectually impaired. And of course, Asperger's disorder will go undiagnosed now. And that's why we said you should welcome all PDD diagnosis in DSM-4 to ASD with the DSM-5. Now this is sensitivity and specificity of DSM-5 criteria, McPartland. It looked into 933 patients evaluated from the DSM-4 trial field, which were exposed to DSM-5 criteria. Overall, there were 60.6% of cases with ASD meeting the revised DSM-5 diagnostic criteria. Overall specificity was 94.9. I've already addressed this statistics. Autism has got like 76%, Asperger's has dropped to 25, and the IQ less than 70 was better than the IQ more than or equivalent to 70. I'm sorry about the symbol there. Now, this is a third paper which looked into application of DSM-5 criteria for ASD to 3 samples of children with DSM-4 diagnosis of pervasive developmental disorder. To summarize, most children with DSM-4 PDD remained eligible for an ASD diagnosis under the DSM-5 criteria. So the diagnosis, there's considerable variability is present in making diagnosis in different contexts. It makes it difficult to interpret trends in prevalence and compare studies. The developed nation, they use different methods and criteria, all right? Whereas as far as Malaysia is concerned, it will be difficult because we don't use standardized assessment tools because it needs training and you need inter-rater reliability, ongoing training, so it's really difficult unless you have a research grant and somebody is supporting you, things will be much easier to have a really nice established diagnosis. Otherwise, we still have to be best practices, practice parameters, and clinical experience and training. Now, the early detection and provision of services improve long-term prognosis, makes early diagnosis important. I want to consolidate here at this point because there's reassurance from grandparents, and sometimes, I don't want to offend anybody, but sometimes some doctors tell parents, because this is from true experience, I have 98 patients in my clinic with autism, and when they come to me, they say, so-and-so doctor said, it's okay. Right? It's okay, you just wait. Okay, if you have a deficit, it's perfectly all right. It's a matter of time, he'll pick up. And then when by the time the patient comes to you in the clinic is 4 or 5 years old, things are delayed. So you have a concern, there is a delay in 2 or more developmental domains and you are worried, you need to address this issue. I'll come to you much later about to whom you can refer these patients. Now, clinicians should be sensitive to ethnic, cultural, or socioeconomic factors that may affect assessment. Here in Malaysia, we're multicultural, multiracial, so you got to be very careful about what you say, what you don't know, what you know, and your understanding about each ethnic, at least the major ethnics that are present in Malaysia. You must address and understand their things, their practices. Now, psychological assessment, cognitive ability and adaptive skills is indicated for treatment planning and helps to frame observed social communication difficulties relative to overall development. I would like to address this to the members from the Ministry of Education, okay, and also Ministry of Health. We still lack clinical psychologists in this country, very few in the hospital practices, and parents have to queue for private practice, and it's quite expensive. And we need to have, ideal world in Malaysia, we need to have clinical psychologists in all government hospitals, number one. And as far as Ministry of Education is concerned, we need to have an educational psychologist in all schools. Once you have the psychologists in the system, then things are easier. There's no issue about having to make a diagnosis, waiting time 6 months, a year to see the child psychiatrist, to see the so-called pediatrician who is competent in assessing the patient. You can't wait. Here you are sitting and preaching early diagnosis, early intervention, and there you have a patient, oh, the appointment is 6 months' time to a year. All right, so it's timely to have this. I can't stand and advocate for the psychologists over time. Over the years, I've spoken to them and working with them for the Ministry of Health to place them in all government hospitals. And we hope in time to come, maybe in 5 years' time latest, we will have a psychologist in all hospitals, and educational psychologists will be in the hands of Ministry of Education. The psychological tests clarify areas of strength and weaknesses, useful indeed in designing the intervention program. All right? Now, so parents will come and say to the clinic, now I want a psychologist to do the assessment. Now, this is not possible at this point of time. So we are very highly selective in who gets a psychological assessment. Reason being, we want to know whether this parent are truly committed in the intervention programs for the child. If they are truly committed, then the child is truly deserving. Now, it's not fair to say that only certain groups of child will have a psychological assessment, but because we are hard-pressed for numbers, so we can't cope with the number of patients and the psychology services that can be rendered at this point of time. Now, intervention, individuals with an ASD can present for clinical care at any point in development, any point, okay? So awareness is extremely important. When I was actually, many years ago, when I was going off to UK to do my fellowship, I was in the visa office. So there's a young man who was leaving for Manchester to do his master's in LLB. And then he said, what are you going to do in the UK? And then I said, I'm going to do things with developmental issues, you know, autism. And then he turned and asked me, what is autism? So this is a professional who's asking me, what is autism? All right? So which tells you there is still lack of awareness in our society. Now, you need a multidisciplinary care, coordination services, and advocacy for individuals and their families. When you say multidisciplinary care, in your clinic, you need the doctor, the speech-language pathologist, the clinical psychologist, occupational therapist, to do all these assessments and then come up with your diagnosis. That will be ideal, all right? It'll take years to be established, I think, for Malaysia. The early sustained intervention and the use of multiple treatment modalities are indicated. Now, because a lot of the time we have organizations approaching us to give their pamphlets to say, you know, can you introduce our organization? Yeah, we will. But the thing is, we don't have that kind of energy to visit all these organizations to see which one is the best. All right? Everyone have got their own school of thought, own school of learning about what is the best practices. So I honor them in every way. As long as my patient makes improvement, you see a good improvement in the developmental trajectory, you are happy. The parent have to be happy, the patient making progress, the clinician is happy. Now, it will be some years before the implications of DSM-5 criteria for other facets of assessment and intervention can be fully assessed. Now, so the intervention, the DSM-5 will affect several dimensions, access to services, education, and broader policy. Now, this is important in the US because please correct me, Prof. Connie, if I'm wrong, and Dr. Andy. I understand that each states have their own education program, and we were told that services to patients are based on the diagnosis that the clinician is giving, right? That's how your service comes. So if you have this diagnosis, this is a service provision, the system is in place, well established, whereas for us it's different because it's still very broad. We don't have this regimen here yet. The treatment can be either medical or education. Now, because you know now with DSM-5, the ASD can come with other comorbid, I would like to address this journal, which says attention deficit hyperactive disorder can be diagnosed along with ASD, where you can use pharmaceutical management. Generally, we use stimulants and behavioral intervention. Now, the positive outcome with stimulant improvement you see in executive functioning, a reduction in stereotypy, aggressive behaviors and irritability. Now these aggressive behaviors and irritability you tend to see in a child who's about 9 to 10 years old and going into adolescent phase. So if you have not made the diagnosis and you have this and they come under the category of intellectually disabled, but in reality they may have been an ASD to start with, all right? So you need to address this executive functioning. Now, ASD and ADHD, you have parent training to improve emotional regulation. So the treatment is just not addressed to the patient, but also to the family. Parents need parent training for patients with ADHD because you think the patient is the only factor, the index that we need to treat. But in reality, you need to get the whole family involved. So you need parent training and medications to improve attention for the patient and before receiving social skill training. So you focus in the current symptomatology. The current symptom is ADHD, address the ADHD, and then worry about social skill training later. So the education in Malaysia, educational eligibilities, whether it's fortunate or unfortunate, are determined using medical diagnosis. And autism comes under the heading Masalah Pembelajaran. Masalah Pembelajaran means learning disability. But with the revised DSM-5, our diagnosis is actually learning disorder. You got mainstream for those who can function at schools, primary and secondary. We can have special education where parents are not happy because they say the autistic child is together with a Down syndrome. You can have a Williams syndrome, many syndromes sitting in one classroom. Although it's a small classroom, 7 students, and then you have a teacher assistant there, yet parents are not happy because they will say, my child is not Williams, my child is not a Down syndrome. And very often when we say special education in our practice, parents say, no doctor, my child is not a Down syndrome. They will be put together with a Down syndrome, all right? These are the concerns from parents. You have non-governmental organizations. We have the NASOM, okay, it's a registered, and we have many other as well. NASOM is National Autistic Society of Malaysia. They are in link with the National Autistic Society of the UK. And homeschooling. A lot of parents prefer homeschooling. Homeschooling means there must be funding feasibility. It can be a few thousands. Finally, looking into autism data, I got this. Thank you to Dr. Aminabi, Matron Chio, and Dr. Salmia, courtesy from them. It's the Health Information Division, Ministry of Health. We have data collection, but you have to take note that in Malaysia, there is still a social stigma. Parents don't want to register. So I don't want to a label at this point of time. They even send their school to mainstream without a diagnosis for ASD. We respect the parents' wishes, all right? We respect. We don't enforce into them, no, you have to register. So this may be an underestimate of the true reflection of autism in this country. Screening and assessment, effective from January 2012. We've got a health record book from the age of 0 to 6. Okay, I just got a few more to go. 0 to 6 years. You can have MCHAT screening at about age of 18 months. We've got 238 family medicine specialists. Those numbers are pediatrician, child psychiatrist, and developmental pediatrician. Now, each of these groups are capable of diagnosing a child with autism, so you know who to go to, all right? The smaller the number, which means the longer your waiting time. The higher the number, the faster your waiting time. So really, Dennis Cantwell is an icon, is a legendary child and adolescent psychiatrist, which is involved in DSM-3 task force. He says kids don't read the DSM. Really doesn't matter as far as the child is concerned. The concern is the clinician and the parent. To summarize, DSM-5 introduces a controversial shift away from discrete and independent categorical entities within the PDD spectrum to a single construct of ASD. Specificity improved, but excluded a substantial portion of cognitively able individuals, female patients, and those with ASDs other than autistic disorder, that would be Asperger's. DSM-5 criteria holds a significant public health outcome regarding service eligibility and compatibility of historical and future research. It will provide a more specific framework to guide diagnosis, prevalence, treatment, and research, while continuing to acknowledge a heterogeneity of this disorder between individuals and amongst individuals within themselves. So therefore, DSM-5 should be welcomed and embraced. The future, the effect of DSM-5 diagnostic criteria on diagnosis and intervention can be determined truly when this criteria is consistently applied and thereafter research conducted. This is my final slide. Now, I would like to take great honor in promoting this NECIC. It's the 5th National Early Childhood Intervention Conference that's run in this country every 2 yearly. The next will be from the 4th to 7th June. The closing date is on 30th April. Please come. You have many professionals, and participants are both professional and parent allied health science to support in varieties of disability. The president is Dr. Amar Singh. So community pediatrician has done eminent work in this field. It will be in Perak. So if you Google 5th NECIC, you will get to this. So please welcome to this conference. Thank you.
Thank you. Thank you very much to Dr. Ranjini for addressing the interesting topic, and hope all of her explanation be an eye-opener for some of us who are still having difficulty understanding the DSM-5. And for others, hope it become an additional knowledge. Or perhaps after hearing what she said, some of you over here are thinking about taking the DSM-5 yourself. Okay, so in today's paper, actually, there are a few articles that come out about in the Straits Times. PM's unveils plan for Autism Center, in which he said that it is aimed at producing a comprehensive early intervention system. And also our First Lady said that autism need to be tackled at young age. This is in the Straits Times today. And also Ms. Samia Wazid Hussain from Bangladesh Global Autism Public Health says that Southeast Asian countries can develop own therapy, in which she said that we should work together to develop training modules and intervention for autistic children which suits the local culture. So, yeah, it is in the paper today. So, now we are now open for the floor for question and answer. We can have maybe 2 questions. Please say your name and your organization. You're welcome.
Okay. Hello, my name is Teo. I'm a parent. My son was diagnosed as having ASD with ADHD at year 2. Now he's 9. I actually wonder, maybe he's actually Asperger or maybe high functioning. Should I get it re-diagnosed? Or sometimes I think if I get it re-diagnosed, right, I actually deprive other children who have yet to be diagnosed, because it's so hard to see a child psychiatrist, right? So every time I think of seeing a child psychiatrist, I think maybe there are many others who deserve more than him. So should I get him re-diagnosed?
Okay, thank you for your question. I look at your question in a different perspective. Now, my concern, as if I were a parent, I wouldn't be bothered about the diagnosis. My concern will be, at this point of moment, what are the interventions that are readily available, easily accessible, to make sure the planning of your child's intervention is very individualized. You've got someone who's looking into his intervention very diligently from time to time. I think that's more important. Did I answer your question? If you want a re-diagnosis, it's basically you're still in the state of denial and you basically want reassurance. I think at this point of time, you don't want a reassurance. You want to address whether there are any other comorbidities. You also need to know the 70% of children with autism spectrum disorder will have one comorbid diagnosis, and 40% of children with ASD will have 2 or more comorbid diagnoses.
Any more questions? Yes?
Yeah.
Assalamualaikum, selamat pagi. Saya Nur Afiza binti Muhammad Fuzi daripada JKM daerah Kuantan, Pahang. My question is, does the DSM-5 will be used by all doctors in Malaysia when it comes for registering OKU card that is under learning disability? And if not, can you explain in a simple way what are the approach using by doctor for clarifying patients under learning disability that is under the form of registers for OKU card, ADHD, autism, syndrome Down, and GDD? And does it come only the doctor can diagnose all the learning disability just one day? I want to ask because I have no experts in medical. Okay, thank you.
Okay, thank you for your question. Your first question, which states whether you need the DSM-5 diagnosis, I will say no. Not at this point of time, because we still need training and good experience in order. In an ideal situation, yes, because it will revoke a lot of problems. And of course, I think Dr. Amina will be in a better position to answer, because you want to change the whole form. I think it was just revised recently, and I think it'll take a lot of energy and money, funding. If it's not going to change your service provision, then I don't think you need a DSM-5 diagnosis into your welfare form. Number 2, assessment of learning disability does not take place in one day, because you need to work together with the teacher. We have got what is our Linus program, Literacy and Numeracy Saringan, which is already embarked some time back. We have assessments for children in the month of March, June, and September, 3 times a year. So you have something called Tegar, Aliran Tegar, and you go for remedial classes. Now after the remedial classes and pemulihan, they have got 35 hours for either Bahasa Malaysia and mathematics, depending on how committed the teachers in the school are. And then they have this assessment from time to time. The moment the teachers think this is worrying, this child cannot remain in mainstream, then they will report to the nearest area for family health medicine to do an assessment. And then only you get a diagnosis. You need to review about a child's schoolwork. You need to work with a school teacher, provided you have parents who are very committed to address this problem. Now, there were instances where these patients come to our clinic, we do a detailed assessment. At the end of 2 hours, the parents will say, thank you very much for the diagnosis, but I don't want my child to be in special school. So we have to respect them. We can't sign the form to say that this child deserves special needs education because the parents don't want the parents want the child to remain in mainstream school and go through the difficulties. All right, we have to respect them.
Good morning. I have one comment. My name is Dr. Ong. I'm from the Dyslexia Association of Sarawak. I wonder whether members in this audience are aware of this boy, this young boy. I do not know how old he is, probably about 12, 13, young adolescent. His name is Nivan Anal. Now he has autism and he writes for The Star on Saturday. So I'm holding his article. This is the second article that I've read, Recognizing the Strange and Gifted. Now it seems, correct me if I'm wrong, it seems that Nivan is non-verbal. But the way he writes, it is just incredible. He writes so much better than many of us. So although he does not have verbal language, but he could just verbalize his thoughts on paper. So he's using the iPad. So this is just to make aware parents of autistic children that besides deficits in our children with autism, there are so many areas of strength. So like what has been mentioned, the support services, opportunities for such children to express their gifts and talents. I guess we have to be aware of that and provide for. So those of you who are interested to read Nivan's article, yeah, please, you can come to me. And if Nivan's mother or relative is here, I would like to meet and really convey my congratulatory wishes to this young and talented boy. Another point that he raised is about the Permata Gifted Program that are provided for children.
Please make it short, please.
Yeah, who are intellectually superior. But he is asking whether children like him should be in this gifted program. Thank you very much.
Thank you, Dr. Ong, for your enthusiasm in coming up several times in this conference to express your ideas and views. We really appreciate that. I'm sorry I can't answer for the Permata Pinta because I'm not involved in the patient selection for this group. You should ask the expertise in that field. Students, yeah.
Okay, since we don't have enough time, if there's more questions, yeah.
Can I?
Okay, please, Dr. Asna.
Yeah, just to respond to Dr. Ong's question about children who are twice exceptional, meaning children with autism and also who have IQ above 110. For your information, there are already 3 kids with twice exceptional abilities. They are already in Permata Pintar. Thank you.
Yeah, don't mind, I just want to ask about medication. Just a short one. Okay, I'm a parent. All right. Doctors, can you please clarify about medication? Because when my son was young, the doctor says, oh, you have to take care of 10 children because he's very active. So he didn't want to prescribe medication. But now, I tend to hear that quite often, doctors prescribe medication just to calm the child. Because that can be quite dangerous. Because maybe you should tackle on a different approach rather than just simply giving medication. Thank you.
Thank you for the question. We clinicians, when we prescribe medication, we look whether there is an FDA approval. So if you're looking into psychostimulants, okay, for attention deficit disorder, we don't give for children less than 6. We abide by the rules that has been laid by FDA. So generally it's after 6. But if it's less than 6 years of age, you go for behavioral intervention. 5 years of age, FDA approval, revised FDA approval.
I think we don't have... Sorry, we don't have the time. If you have any more questions, please ask.
Sorry, I have
Dr.
a general,
Ranjini.
just one comment. Can I just indulge a little bit on function? Yesterday at some sessions we talked about the medical model. I think in today's discussion, it's very obvious that we should focus on function rather than the diagnosis for parents out there. And for doctors and medical people, perhaps we should start thinking seriously about using ICF, the International Classification of Functioning, Disability and Health, regardless of what diagnosis the patient is at. After all, for the person, for the registry, the definition, the 7 categories of disabilities, one of the criteria is permanent disability. And it is better to look at function rather than to look at diagnosis. After all, very often we cannot confirm diagnosis. Thank you. I'm Zaliha from Malaysian Information Network on Disability and from Langkawi Inclusive Community Outreach Foundation. Thank you.
Thank you very much for the information. So if you have any more questions, you can ask to Dr. Ranjini personally. And on behalf of the organizing committee, to once again thank Dr. Ranjini for the fruitful discussion. And once again, ladies and gentlemen, a big clap to Dr. Ranjini. And see you again on the 4th to 7th of June. Thank you.
Thank you very much, Dr. Yasmin Hussein and Dr. Ranjini for the updates on DSM-5. Ladies and gentlemen, now it's time for the 4th plenary session, and I would like to call upon the moderator for this session, Professor Dr. Zuria Mahmud, the head of the Department of Community Education and Wellbeing, Faculty of Education, University Kebangsaan Malaysia. Please welcome.
Hello. Hi, good morning and Assalamualaikum. Welcome to the 4th plenary session of the International Seminar on Autism 2014. I am Zuria Mahmud from Faculty of Education, and I'll be moderating this session with Professor Connie Kasari. We didn't have a lot of chance to get to know each other just now, but I'm sure she has a lot to share. And the topic will be State of Art, Early Intervention in Autism. I would like to introduce some information about Professor Dr. Connie Kasari. She is from the Education Department, University of California, Los Angeles. Her research interest is on social, emotional, and cognitive development in atypical children, randomized controlled treatment studies of social and communication behavior in children with autism. And Prof. Connie will be presenting in 35 minutes. I'll be telling you, the minutes that you still have, and then we'll have some Q&A sessions after that. So, without further ado, I would like to invite Prof. Connie Kasari to deliver her plenary talk. So, you're welcome.
Thank you. Thank you. I'm happy to be back again today, and we're going to hope that these slides work. They will work because I have help. Okay. I knew I needed help. Thank you. Okay, we're going to talk about early intervention and state of the science, sort of what we know about early interventions so far. So without taking much time, we'll, let's see, I don't have slides, do I? Are we up with slides? Aha. So there's my beach. So I came from California, that's far away, to your beach, which I haven't seen yet, but I'm sure is lovely. All right, so today I want to talk a little bit about what the evidence is for current early interventions, what we've learned from research, and what the future holds. And I want to start by talking about a little boy that came to us for early intervention. He was 22 months old, but he was 8 months developmental age, so he was very delayed. And we taught his mother some strategies over a very short period of time, about 3 months, and they lived in another state. And so I was doing a talk at this center in this state, and this little boy comes up to me. He's now age 7, and he said, "Hi, Dr. Connie." And it turns out that he's fully included in regular school at age 7. I would never have predicted that from having seen that little boy at 22 months. So I think we're still not quite able to predict who's going to have an optimal outcome or not. But in this case, this child had a mom who was incredible, very committed, never let this little boy go. And so from those early strategies, she really was able to mobilize his services, and he did quite well. So I think we have great hope for the future. So what we know from early interventions is that behavioral interventions work. We don't yet have effective medications that target the core deficits. As we just heard, they can help us with some of the comorbidities, some of the ADHD or some of the anxiety. But the core deficits, we're not there yet in terms of medication. It's also clear that one size does not fit all children. So we need to have a variety of treatment approaches. There haven't been comparisons of different models, so we actually can't determine which model is best. And the most effective interventions use a combination of very structured and naturalistic strategies. So we know that behavioral interventions result in higher cognitive skills, better language skills, improved social skills, and families are less stressed and happier when they have access to early intervention for their children. So what are early interventions really about? Well, in the United States, parents often request applied behavior analysis and a particular kind of ABA called discrete trial training. This approach involves a repetition of very discrete skills, and it's really likely more effective for some pre-academic tasks, such as matching or sequencing. And as I'll talk about, it's not as effective for some of the social communication skills that are really core to the disorder. But here's an example of what this looks like. This is a 4-year-old boy in his school receiving discrete trial training on a matching task, which is very common.
Match. Hooray, that's matching. It's toys. Match. Ready? Match. Match. Hooray, high five. So good. 2 more. Match. Match. You're so awesome. 1 more. Match. Wow! Hooray! High five!
Okay, so those kind of interventions work well, and they're great, and they're probably necessary in early intervention, but they're not the only approach, and they aren't as effective for some other skills that you might want to target. So what we know to date is that behavioral interventions require a lot of intensity, often high dose, so 20 hours plus per week. The structure is one-on-one. It requires highly trained professionals, and the outcomes that people look at are changes in IQ or in sort of this set of developmental skills that show that the child is closer to what a typical child can do at a particular age. There's new evidence that indicates that results can be obtained with far less dose and structure, but challenges still exist in who benefit most from these current interventions, with about 1/3 remaining minimally verbal. So that's a concern. So some children are remaining minimally verbal even though they've had access to all of these different interventions. So that's a challenge for us. So what have we learned from research? So I'm going to talk, you know what, this is an older version of this presentation. So I think you gave me the one that wasn't. Can I just get out of this quickly and go to the right one? I knew I should have trusted my memory here. Let's see, is it that? No. How do I do that one? Aha, see? Oh, it looks the same. All right. Well, so what I want to talk about is what we've learned from research. So talking really about very early interventions and active ingredients. So what we know about autism is that it develops over time, and it requires the need to develop very early interventions. Increased research on high-risk infants has really been prevalent in the United States or in North America, and that's children who have an older sibling with ASD. So the North American statistics are that about 19% of younger siblings will be diagnosed with ASD by age 3. And that's higher if they have more than one sibling or if the child's a boy. What's interesting is that at 6 months of age, these babies just look fine. They look like typical children. But beginning at around 12 months, we start to see that babies are losing some of their social communication skills, or they just fail to make progress. So there's this variable age of onset of ASD from about 12 to 24 months. And that's a concern. So you can see in this study that was done by a whole network of North American researchers led by Sally Ozanoff, that children at 6 months have eye gaze and social smiles that look about the same, but that it diverges over the next year, with the graph in red being the children that are later diagnosed with ASD. So what's the effect of these early signs of autism? Well, it really affects the foundational skills for social development, cognitive development and learning, and language. These basic early symptoms are all critical for later development. So if you think about how these early signs develop into play, into joint attention, or gestural communication, and imitation. And if you don't know what joint attention is, it's a very important skill, and I'm going to show you a little bit what it looks like in a video clip. Early signs of social communication. First, I want to show you a typical child who's 17 months old, who's getting an assessment on social communication skills.
Charlie, Charlie! It's a cow!
Monkey.
It's a monkey! Oh, and a parrot? Parrot? Whoa! Charlie, Charlie! It's a crab.
So he's following points, which is following joint attention. He's pointing himself to share attention with the experimenter. And that pointing to share is what's really important in what we think children with ASD don't do very much of, which is to share attention about some event or something with another person. So here's a little boy who's 17 months old who's getting the toddler version of this diagnostic instrument you've heard about over the last day or so, the ADOS.
Yeah?
All right, so he's fascinated by that toy screwdriver. And the experimenter is trying to get his attention, trying to share something, and it's just not working. And that's very common. All right, so experimental studies have really redefined our approach to early intervention. So all of these research studies on the core deficits and really understanding the presentation of children with ASD has led us towards these kind of modularized, targeted interventions that address core deficits. This is especially important because IQ isn't a core deficit. So the majority of children function in the typical cognitive range. They might be delayed, but we don't actually think of them as having intellectual impairment, right? It's comorbid for some children. Anyway, it's not a core deficit, but social communication are a core deficit. The modules, when you think about developing an intervention module, is that it can be applied flexibly, standing alone as an intervention for young children or added into a comprehensive school-based intervention. And the evidence is strong for improving core deficits using modular treatments. So joint attention with parent, or joint engagement with parent improves. Joint attention skills like pointing and following points, all of that improves. Play skills improve. Our children often don't show very much imaginative or symbolic play, and that can be improved. And their language skills improve. So children who develop more joint attention skills and engagement with their parents actually have greater language skills later on.